Hi, my name is Eric, and I love drugs. Specifically, I'm a physician, and so I love drugs because they're able to help me help people recover from whatever illnesses they've asked me to help them with. I'm also a pharmacologist, and for that reason, I love drugs because they tell you a lot about what's happening inside of a body, and we can learn a great deal from them. So I'd like to tell you a few drug stories. Let's start with A for acetylcholine. Not only is it the first letter of the alphabet, it literally was the very first substance that was ever identified as a neurotransmitter. And I think the story of acetylcholine illustrates very well the ability of drugs to tell us about how nature works. If we simply listen to their messages, we can discern a great deal. I guess to steal from my conclusion on this, acetylcholine was discovered around the turn of the prior century. So before we had all sorts of very fancy chemical equipment or X-ray crystallography or genetic technology, we were able to learn that acetylcholine, one, is a neurotransmitter substance. Two, we actually learned that such things exist. Not only that, but we were able to deduce with nothing but observation and reasoning that acetylcholine has several types of neurotransmitter receptors. Just through drug observation. Specifically, we know that if we apply acetylcholine to a smooth muscle, like a small intestine, like a section of small intestine, we can get that smooth muscle to contract. Similarly, if we apply acetylcholine to a skeletal muscle, like a biceps muscle, or actually, as was done in those days, the calf muscle of the frog, acetylcholine will make that muscle contract. So acetylcholine is a muscle contracting chemical released by nerves. And then there's a mushroom called Amanita Muscaria. In Swedish, they call it Fluoxetine, which means fly mushroom. And I think in English, it's called the fly agaric. I never know how to pronounce that. But it's a mushroom, poisonous mushroom. Or some people actually consume it in lower doses for hallucinogenic properties. Nonetheless, it has chemicals in it that are active. Taking muscarine, the primary neurochemically active ingredient of Amanita Muscaria mushrooms, we found that muscarine applied to the smooth muscle will result in a contraction, just like acetylcholine did. But when you apply muscarine to the skeletal muscle, nothing happened. And then I don't have the chemical that needs no introduction, nicotine, was available in the day, and they applied nicotine to smooth muscle, and nothing happened, but it contracted the skeletal muscle very well. So nicotine and muscarine could both elicit the same degree of response as acetylcholine, but they had differential responses according to the type of muscle. This led to the idea that there must be different kinds of proteins or receptor substances that mediate different responses, and that view was correct. So drugs tell us stories, and if we listen to them, we can learn quite a bit. And just for the benefit of review, acetylcholine is a neurotransmitter made throughout the body. Muscarinic receptors and nicotinic receptors are quite different entities. The muscarinic receptor is a transmembrane receptor protein that has 7 transdomain loops that cross up and down that are embedded in the cell membrane. When acetylcholine binds to it, it stimulates a G protein, and that changes the level of receptor of second messenger chemicals inside the cell, and that ultimately affects whether the cell becomes more or less excitable. Nicotinic receptors are entirely different. Rather than having a single long protein that has 7 loops going up and down, it has 5 different proteins or protein subunits that glom themselves together to make an ion channel. Normally it's closed, but when acetylcholine binds to it or when nicotine binds to it, that channel changes its shape, opening up a pore in the middle of it, allowing sodium to flow through and resulting in fairly rapid depolarization of the cell. So there you go. Acetylcholine, 1 neurotransmitter, 2 subtypes, and within those subtypes, there are many subtypes that we've discovered through gene cloning and analysis. So another drug story, penicillin. This tells us that, again, we can learn a lot about diseases just by observing what happens with drugs. Penicillin is, as folks know, an antibiotic. It has a very specific action on bacterial cells, and it very specifically kills a family of bacteria species known collectively as the gram-positive bacteria. And thus, if we have somebody who is having a fever, maybe we can add to the fever a cough, and we give them a few doses of penicillin, and we start to see that the fever and the cough begin to subside within a day or two, and maybe in 3 or 4 days it's completely gone. There is a pretty high probability that that person or those symptoms were caused by a gram-positive infection. We actually don't need cell culture experiments to prove that. Penicillin is very specific in what it does, and so the drug response tells us the answer. And on the other side of the coin, if we have the same set of symptoms, a febrile patient with a cough, and we give that person penicillin and nothing happens, then we have to start entertaining the possibility that maybe those symptoms have some different cause that does not involve gram-positive bacteria. So what we've done for penicillin has been applied to psychotropic medications with glee. We've been very happy to use the knowledge about the pharmacology of various psychotropic drugs to develop theories about the causes of mental illness. The so-called antipsychotic drugs are designed primarily to block the signal of dopamine. Thus, we developed the idea that schizophrenia and psychosis in general is related to an excess of dopamine signaling in the brain or body. Similarly, antidepressants generally have a common theme of augmenting the signal of the neurotransmitter serotonin. And so that was a piece of data that informed the theory of depression as a so-called chemical imbalance. Fun fact, it's actually more of a memory imbalance than a chemical imbalance, but I digress. Nonetheless, the action of the drug gives the idea that that depression has something to do with serotonin being awry. So, side note and segue, we're curiously, although we can develop these theories, the field is very reluctant in ways that don't make sense to me to revise those theories when drugs don't work. For example, the dopamine receptor blocking drugs, the so-called antipsychotic drugs, actually don't work in maybe 30% of people with schizophrenia. So that should be telling us that 30% of schizophrenias don't have that much to do with dopamine. And about half of depressions don't really respond that well to serotonin signal augmentation. So that ought to be a clue that not all depressions are serotonin diseases, but that gets far afield. By the way, this lecture, as you may intuit, is not specifically an evidence-based lecture. I'm not going to cite massive studies of multi-site, multi-thousands of volunteers with placebo controls. Rather, I'm going to call this study a logic-based study. So I'm going to tell you about how things work and let you work through the deductions about what that's trying to tell you. So on the topic of medication non-response, what does it mean when symptoms don't respond? Well, I've sort of foreshadowed this. If the person with a cough and fever doesn't get better from penicillin, then there is a reasonable chance that that person's symptoms are not the result of gram-positive infection. If the person with a psychosis doesn't get better from drugs that block dopamine signals, there's a reasonable chance that that person's symptoms don't have that much to do with dopamine, and so on. But that's, I think, not a widely held view. We tend to, even though there's no evidence to support this, we tend to think of psychiatric diseases as monolithic or single cause. So schizophrenia is thought to be a etiologically homogeneous disease, and I think that although maybe not many clinicians will go so far as to endorse that they believe that, the practice that I observe in my consultations suggests that a large number of people behave as if they do. So if you think that there's just one cause of an illness and your drug is not working, then the logical explanation for that medication failure is that the disease is more powerful than your drug has to offer. So I think that notion informs the fairly common practice of doubling, tripling, quadrupling the dose or adding 2 or 3 medicines with similar mechanisms of action. So, because I see with great frequency as a consultant for treatment-resistant depression, a person will be on 3 times the dose that's recommended for a drug like Prozac. Then they'll have some trazodone, and they'll have some venlafaxine or some other things. So there'll be multiple drugs that target serotonin to sort of augment that, and oftentimes that doesn't work. And it's a digression on the topic of jacking up the dose to try to address treatment non-response. I'd just like to remind folks that another thing I love about drugs is that they behave in extremely predictable ways. And one of those predictable ways is that they bind to target proteins according to this curve. So as the concentration rises, the attachment of the drug to the target protein will increase up to a point, and then you have a bending of the curve where it becomes asymptotic. In this example, we are looking at data from the binding of aripiprazole to the primary target D2 receptor. And you'll see here that at 1 and 2 milligrams, between 0.5, 1, and 2 milligrams, there's a rapid increase in the percentage of D2 receptors that are bound by the drug. But between 2 and 10 milligrams, there's not proportionally such a large increase in binding. And between 10 and 30 milligrams, there's really no significant increase in the occupancy of the target receptor by the drug. This is, as I said, common across the board. Let's look to the more commonly used drugs, for example, just to emphasize this point. These are dose occupancy curves for sertraline, aka Zoloft. You have here the two graphs, same graph, just different labeling on the x-axis. On the far left, you're looking at actual dosing in milligrams. On the right, you're looking at the corresponding plasma concentrations. And the same, it's called a hyperbolic curve, a rapid rise and then a flattening at higher doses or higher concentrations. Note here that we get to the asymptotic or the flattening portion of the curve at around 50 milligrams of sertraline, and really there's no appreciable gain in binding between 50 and 200 milligrams. It's, by the way, interesting that the approved starting dose for sertraline is 50 milligrams. That's because the pharmaceutical manufacturer knows what these curves look like, so they're going to market their drugs at the doses at which the binding is saturated. The other thing that I'd like to just point out for reference is this thing at the bottom, the ED50. That stands for the effective dose at which 50% of the target protein is occupied. And for this drug, sertraline, aka Zoloft, 9 milligrams is sufficient to target half of those receptors. So that's that. This curve is for fluoxetine, also known as Prozac. Look here, the Prozac is marketed at a starting dose of 20 milligrams. At 20 milligrams, you see that you have 80% saturation, and really no appreciable increase in saturation occurs between 20 and 60 milligrams. The ED50 for fluoxetine is an amazingly low 3 milligrams a day. So you can have significant drug activity in the brain at 3 milligrams and maximal drug activity at 20 milligrams. And one more curve, we'll look here at venlafaxine, aka Effexor. This is a serotonin norepinephrine reuptake inhibitor, but again, we're looking in this case at the serotonin binding. ED50 at 6 milligrams a day. You've achieved saturation of the serotonin transport protein at, about 75 milligrams, which happens to be the starting dose that's recommended in prescribing information. And once again, you see no further increase in serotonin receptor occupancy between 70 milligrams and 200 milligrams. So the point of that is that enough is enough. If you want to, if the idea that in treating depression you want to inactivate the serotonin transporter, you can achieve that at the lower end of the approved dosing, and you're not going to have meaningfully increased binding to that target protein at higher doses. So the notion that we should be doubling, tripling, quadrupling the dose to combat treatment resistance is not well supported by graphs like this. So how do we explain then medication non-response? Well, in a view of depression as a disease that looks the same, even though it might have different underlying causes, medications fail because the drug is not addressing the primary cause. In the case of schizophrenia, the dopamine receptor blocking drug, the so-called antipsychotic, may be fully doing its job at binding to and inactivating dopamine receptors, but the psychosis would persist because maybe it's due to inflammation or to aberrant glutamate signaling, for example. So I think it's useful to keep that in mind. And from a pharmacologist point of view, that's the message that drugs are trying to tell us. To, again, illustrate this point, I designed this thing I call the depression stadium hypothesis. The game looks the same, depression looks the same, no matter how you approach it. So in depressions, you can have significant cause by simply losing your friends or not having friends or having low quality friends. You can enter the phenotype or the symptom expression picture of depression through having personality traits that make you more prone to worry or rumination. You can have depression symptoms because your life simply, you haven't thought well about meaning and purpose in your life, and so you experience life as devoid of meaning, and that can translate into low energy and depressive symptoms. And you could have depression because you have a biochemical abnormality in serotonin signaling. Or other numerous, or through inflammation properties, inflammation disorders as well. So as I say, a little bit snarkily, to exit the stadium is usually the most efficient to go out the way you came in, and in a more pointed way. Prozac is not a substitute for not having friends. So I point this out because treatment-resistant depression is very common. It's been a staple of my consultation practice, and the number of times that very obvious environmental, psychological, social, or spiritual pain has been just not recognized, while at the same time the person is getting, frankly, overdosed with medications, is, I think, common enough that I want to make this point. And then to just further, expand your way of thinking, or to maybe blow your mind a little bit, what do you, just think about the meaning of this, that conditions as seemingly diverse as major depression, generalized anxiety, PTSD, and OCD all have as their treatment of choice the same kind of drug. So serotonin augmentation is a good way to treat all these diseases. Does that really mean that these diseases should be regarded as separate nosological entities, or are these just various ways of expressing a serotonin signaling deficiency? And the same argument, the dopamine antagonists, the so-called antipsychotic drugs, are fabulously effective for the majority of cases of schizophrenia and psychosis. They're also fabulously effective to resolve bipolar mania, and they're also fabulously effective as adjuncts in so-called treatment-resistant depression. And the same question, what does that mean about the real truthful significance of having three separate categories when the same drug is useful across all three? And the drug is, I'll answer that question. The drug is trying to tell us that these distinctions that we've made are maybe not supported in biological reality. And modern genetic studies are reiterating that between psychosis, between schizophrenia, bipolar disorder, and depression, there's a lot of genetic overlap. So drugs usually get it right, and it's our job to catch up with what they're trying to say. So to conclude, drugs are always telling us a story. In addition to working as therapeutic agents, it behooves clinicians to always keep in mind that there's a story coming back from the patient drug scenario, the patient drug combo, and it's helpful to be thoughtful about the meaning of that. Drugs are telling us that maybe the way that we've organized diagnosis is not really in line with the way the biology works. And that's no surprise, because the DSM is designed to be reliable in naming things. It never had any intention to be biologically valid, and drugs are sort of showing us that that's the case. And it, just in case anybody's upset, by biologically valid, I mean depression does not, it was never intended that the DSM diagnosis of depression is going to correspond in any way to a particular neurotransmitter or gene type. That's actually why a lot of genetic studies to try to find the genes or the chemical studies to try to find the biochemical signature of depression generally fail, because depression is like many diseases. It's not going to map to a single gene or biochemical pathway. And the other thing that I just like to think about to try to help advance everybody's practice sophistication is when you're giving a drug to treat a certain set of symptoms and the symptoms aren't resolving, it may indeed be the fact that the person's not taking the medicine, or that they're a super metabolizer, or some other drug is knocking off the effectiveness of the drug that you're giving, or other things. But I mean, one of the interpretations that you should be considering is that the symptoms that you're trying to treat are not really being primarily generated by the targets that the drug that you chose is interacting with. So those are some thoughts to try to stimulate thought.